back, Caitlin. Finally found a
Yeah,
time to I had my mic sitting down, but I'm still holding my mic and spinning around and still can't figure out what to do with it. But we are back. We are excited to be here with you guys. Um, we have been like anything, we're busy. I always find that funny when you ask people how they're doing. They're like, "Oh, I'm busy." Everybody's busy. But we've been busy. We finally found a time to record, and we've got a great episode today. We're going to be talking about psychotropics. But before then, Caitlin and I are more than just long term care pharmacists. We're human beings, human problems. This is like your
a lot.
free therapy session right here. So what's been going on, Caitlin, in your life?
Oh, just crazy stuff. Crazy stuff. Um, I know I was telling you last night, we have a hound dog, and I don't know if, people know about hound dog stench. It's a real thing. So they actually have like a certain smell to them. So the whole house has been complaining. I washed the dog. She's fine now. Even the kids complaining about it. I'm like, all right, fine, guys. All right, fine, fine, fine. I'll take one for the team. It's fine. And then
How nice of
4:30
you.
this morning, wakes my husband out of the bed, went outside howling to the moon. I don't know what she was doing. He wakes up, he's growing his hair out. He's doing the Riley Green and the Morgan Wallen hairdo. So he wakes up like a rooster, it's just like flopping up on top of his head. 4:30 in the morning, just madder than darn it. Gets up, wakes the whole house up, calls the dog back inside, cussing, everything else. So that's how we started our morning off this morning. Poor Bella. She gets a bath and then gets abused.
Then gets abused. Yeah.
Yeah,
Well,
it's just silly.
good thing you took one for the team there because I always hated giving our dogs baths. So
Yeah.
we've never had a hound dog though, so that one you
Oh,
definitely got on us there.
oh yeah,
Not
85 pounds of it. Yeah.
yeah, not planning on
Yeah.
getting one now that
Yeah.
you've
But
mentioned
they're super
this.
cuddly though. They
Yeah,
love to
I mean,
cuddle.
nothing's better than a super cuddly dog that just
Yeah.
stinks. You
And
know,
very,
it's
very
just
lazy. Yeah.
yeah. I mean, I'm tempted to go get one right now.
I mean,
Y'all
I think you
listening in might be
should.
the same
Hey,
way.
when they're puppies, though, that's not the problem. So,
Yeah, I
they're
mean, well, it's
super
like everything.
yeah.
They finally grow up, right? And then that's when it
Yeah,
really
just like
gets
with
more
kids, you get
difficult.
tricked.
Yeah, that's right. Just like children.
Yeah,
Speaking of children, my daughter wants me to subscribe back to Netflix again. I've kind
yeah.
of gotten away from Netflix for a while, um, and the only reason that she wants that is that all of her little friends at school are talking about this K-pop Demon Hunters thing.
What is that? I caught Ava watching it, and I'm like, "What is this?"
Well, let me just tell you right now that just don't go down that rabbit hole because
Okay.
the songs get stuck in your head. It's one of those
No.
things where you think you're doing something good for your kid and you're like, "Oh,
Yeah,
this is dumb. Like I'm never going to remember these songs." And then you're sitting there
right. Like Baby
like we
Shark.
yeah, like I mean we've been listening to that Golden song. It's like you probably heard it. It's like, "We're going up, up, up,
I
it's our
have heard it.
moment." You know that one? That
Yeah, so
"You
it
and
popped up on
together
my
we're
DJ
glowing," something like that.
on Spotify. I was
Yeah,
like,
and
"What
it's
is
like it's
this?"
everywhere. Gonna be golden," and it just stuck in your
Oh,
head
no.
from then
Oh,
on.
no.
So, yeah, that's what so we had a birthday party to attend this weekend, and the entire 1.5 hour drive to get to there, we listened to K-pop Demon Hunters
Oh, no.
songs.
Oh, no.
It's amazing I didn't come out of the car dancing and doing, like, all the moves to it too, but, um,
Yeah.
yeah.
Oh,
In
man.
case you're listening in, yeah, Caitlin and I can release our pharmacist singing, debut of this golden
Oh,
song.
Lord. Oh, Lord.
Gonna go top on the charts. All right,
Oh, no.
moving on into something much, more probably entertaining for you guys listening in is that this is a long-term care pharmacy podcast, and we want to bring all the education, all the good, info y'all's way. And we're talking about one of the biggest topics, hottest topics that I think is anywhere in long term care has been for a long time, and that's psychotropic medications. Now, spoiler alert before we get into this, we're not going to get into the weeds too much on any one class because we, are likely to do another podcast where we talk just about antipsychotics or just about antidepressants. And Caitlin and I can nerd out, and we'll have to really edit those because they might become so boring to those the people that
Yeah.
are listening, nerding out on the pharmacy stuff, and everybody else is tuned out. Um, but we are excited to talk about psychotropics, some of the history behind it, because we know there's a lot of new people that are entering into long-term care, whether you are a provider, whether you are a pharmacist, whether you're a nurse, doesn't really matter what your healthcare profession is, you're entering into long-term care, and psychotropics play this huge role. I was talking to Caitlin before I got on here. A lot of people that haven't been doing this for a while um, didn't see the years before these recent last 5-10 years where they've really tried to crack down on inappropriate utilization, specifically of things like antipsychotics. I remember walking into facilities and you would see these residents that would just be kind of just sitting in their chair, just drooling on themselves because they were on Haldol, and Haldol
Wow.
was like used like crazy.
Yeah.
For those of you listening in, if you don't know what Haldol is, you might recognize the generic haloperidol that they use. It's actually really good antipsychotic for nausea and stuff related to chemotherapy. But other than that, it's a pretty nasty antipsychotic with tons and tons of side effects. Well, these poor residents were experiencing those side effects, and so you saw these patients that in these residents that really didn't have much quality of life. They were just sitting there and, it just seemingly not really with it. And so as the years went on, CMS, uh, every other, guidance body that was out there started noticing that there was an inappropriate utilization of these medications. And that stemmed from a lot of places. Sometimes it was the hospital, and Caitlin and I can attest to that. We still see the
Yeah.
hospital
Yep.
using those.
Mhm.
Um, and the reason being is they don't fall under the same kind of guidance and stringency that we do in long term care. They actually fall under something called JACO, which has a little bit more leniency.
Mhm.
Um, so, and Caitlin knows this, that my earbud just jumped right on my ear, right in the middle of that sentence. Uh, who knows what's going to happen on here. Um, but like Caitlin and I see this all the time, where an elderly resident goes into the ER. Um, Perhaps they go in for pneumonia or something like that, or maybe a fall, or something along those lines. They get put on an antipsychotic. I used to,
Yep.
when I did a rotation in the ER before I ever went into long term care, I saw them put residents, these elderly patients, on antipsychotics so they didn't have to deal with their behavioral episodes and stuff. And so then it just kind of carries over and they continue it. And then the home has to be the bearer of bad news that they need to get rid of that because it wasn't something that that person needed. And so we see it in that setting. Um, we saw it being utilized for dementia residents back years ago. Still, I think in some instances, we still see that where and it's not necessarily wrong, right? Like, I don't know, Caitlin, if you remember learning this, but I remember DePiro's pharmacotherapy textbook actually listed antipsychotics. I think it still does as a last line therapy for dementia patients with agitated episodes, if I remember.
Yep.
I think Lexicomp does too.
Yep.
Um,
Mhm. Yep, they
and
do.
for y'all listening in, those are like two of the big players for pharmacy education and guidance. And so we saw this kind of like this road of, well, we need to figure out how to get rid of some of these medications that are inappropriate for these residents. And when we talk about psychotropics, I guess we should go back, Caitlin, and mention what those are. And so, why don't you tell our viewing audience here and listening audience what we're talking about when we talk about psychotropics?
Psychotropics are basically a clump of different drug classes that is flagged by CMS to essentially we want to focus on, and they fall under certain rules in CMS like gradual dose reductions, and their target medications to try to get reductions. So that's antidepressants, hypnotics, anti-anxiety medications, um, antipsychotics, and those are flagged under the psychotropics because they come with risks with CNS effects on behaviors and other side effects that each class individually will pose on the elderly population. Um, so the biggest one I think we a lot of times talk about is the antipsychotics. I know in North Carolina that can be a big focus with CMS. Not that they don't look at the other ones, they definitely do. You have the benzos that are underneath the anti-anxiety that they definitely will be watching because those pose a lot of side effects as well. So it's not just antipsychotics. It's kind of like, what are the biggest risks underneath those class that you might see surveyors or facilities kind of home in on. But essentially that's what we're referring to with psychotropics is those different class of medications that have the CNS effects that carry a big, profile of side effects on your geriatric population.
Yeah, and, the questions that I often get asked with relation to psychotropics, I had one home ask me one time, just well, several homes have asked this, but, well, do you
Mhm.
think these residents need these psychotropic medications? That's a hard question
It
to
is hard. Yeah,
answer, maybe. I mean, I don't really know the best answer to that. I don't know, Caitlin, if you've ever had that, but I just feel like it really is very patient specific and
it is.
dependent.
Mhm.
And, past medical history plays a big role. There's a lot of times that we will be looking at a new admission, and in the few instances that we do have their home medications, which seems to be fewer and further between at this point in
Right.
time nowadays,
Mhm.
um, that person may or may not have ever been on that psychotropic. And so, obviously, if they're not, we want to get them back to baseline, which would be not on the psychotropic. It's really interesting, Caitlin. I think when you and I were discussing this before we even did this podcast, there are so many studies that are out there that are really, I think, keying in on. I want us to not like leave this tone in people's ears. And if you're
Right.
watching this, like watching us talk about this, leave this tone that they're completely unnecessary and that nobody ever needs them, period, end of story. Because a lot of these studies that we're going to bring up, I don't think that's what they're really trying to point out.
Mm,
I
right,
think that they're
no.
more or less really trying to point out what we're going to talk about in a little bit called med optimization, and just making sure that it's the right medication for the right patient, similar to kind
Mm,
of the med pass guidance, making sure it's the right med, right dose, right patient, all that kind of stuff. But one of the studies that I read recently, and let me see, I wrote it down over here. It's from, I can't stand how all these studies, I don't know. I think in order to do a study, you have to have a very difficult to pronounce last name. Have you ever noticed that?
yes.
Like, it's
Yes.
it's ridiculous. I mean, not saying that your
Yeah,
names are ridiculous, researchers, but I mean, I
but
don't know how to pronounce that, but
there are.
yeah, it's like Teja. I'm gonna go with Teja et al. And, if you're listening in, which I highly doubt you are, but if you are, then I apologize if I butchered your name. But this was a study as far back as 2010, and this is another question that, and I don't even know as much of a question, but it's something that I do like to go over with facilities, because if you can imagine you as an individual living at home, and you are uprooted and placed into a nursing home facility where you no longer have the same walls surrounding you that you
Yep.
have grown accustomed
Share
to
a
for years
room.
and years.
Yeah.
Um, you don't have the interaction with the same people that you would have had for
Mhm.
years. Perhaps many of those individuals have passed away. that you had interaction with. Family doesn't isn't close by, or maybe they are non-existent. Hopefully, they are present in your life, but don't they're not there all the time, right? Just kind of like at home. But you get into this facility, and the lights are brighter than what you're used to. The place is noisier than what you're used to. You maybe have a roommate now where you didn't have a roommate before. Um, I think sometimes it's easy for us to be like, well, all these meds are not needed because they weren't on an antidepressant, on an anti-anxiety before they came in. Well, it's probably not uncommon for residents to experience some anxiety and some depression when these big life changes are occurring. But what this study really looked at, and this is what I oftentimes tell homes, is that as that resident gets plugged into activities and the nursing staff are loving on them and making them feel like they're part of that family there, and the other residents are making them feel welcome, and all those kinds of things are happening in the right way, then this study highlighted the fact that a lot of those medications like that, like the antidepressants, the anxiety meds, the sleep agents like Ambiens, Trazodone, used off label, all that kind of stuff, aren't needed long term. In other words, once they get acclimated to their setting, then they
Mhm.
were able to reduce most of those medications back off. And that's something that I know, strive as pharmacy consultants to do, but it's an ongoing battle, wouldn't you say, Caitlin?
Yeah, it is. And it goes back to that individualized care. And it is difficult coming from your home, your family, and then going into a completely different environment. And so, there's a transitional stage there and process. And, some of these medications are also linked to environmental factors that are affecting their psychological mindset. And so we know as those things can change with over time, that's kind of why the gradual dose reduction in the CMS regulations is helpful in trying to reevaluate those changes. Because, social factors and, just their day to day activities play a huge role in their mental health, and they may be there for years and have a decline in mental health and just not wanting to engage. And so, even when they are there for a long period of time, you kind of have to watch for those environmental factors that change and their want to go and do things and to be involved, or even if it's sitting outside, or sometimes they lose friends in the facility. That happens too. And so, it
Right.
is an ongoing battle of, readjusting, reevaluating, looking and asking and posing the question, well, is this appropriate at this time? Do they still need it at this time? And sometimes it's initiation of therapy. Sometimes it's not, deprescribing or decreasing doses or getting a medication off. And that's where I think, we're switching to that focus on individualized care and trying to look at, rather than the deprescribing method and terminology, but the optimization of like their therapy and where they are and what's best for them at that point in time.
Yeah, and I think that's really important. I mean, even the regulations themselves, we've thrown around terminology here that if you're new into long term care or maybe a seasoned veteran in long term care, you may have heard, but it may be something that you don't normally deal with because if you're a nurse listening in, it's not like you're sitting around worrying constantly about gradual dose reductions. No, you're worried about taking
Right.
care of patients, right?
Mhm.
And same thing with nurse practitioners or doctors. That's not your constant concern. But gradual dose reductions, even the way that the wording in the regulations has been edited. Now, mind you, I have been around CMS long enough to know that when they do things in a vague way, that's, typically trying to open up people for more deficiencies. But
Yep.
one of the things that they did with this most recent reg change related to gradual dose reductions is they kind of had it in this two within the first year and then yearly
Yeah.
thereafter. So basically, what that means is when the person was started on a psychotropic medication, within the first calendar year from that initiation start date, you had to request or attempt to gradual dose reductions, which just means you're reducing the dose. And the whole concept of a gradual dose reduction is to try to get them on the lowest effective dose
Yeah.
to treat the condition, right? And that should be kind of the goal for every medication, but especially for psychotropics. And what they found with that is it's very regimented. You know, it was this person that was maybe benefiting from this at times might have gone into a gradual dose reduction attempt. They destabilized. That person would take even more of the dose to get back to being stable again, because that's how sight conditions work, true sight conditions. If they destabilize, sometimes it takes even more to be able to stabilize that person again. So now you're opening them up to more side effects, et cetera, and so forth. So the way that they change the regs now is quite unique because it's more along what Caitlin was talking about, where it's centered on that person as an individual. They do want you to find these routine kind of times where you're asking for a gradual dose reduction, but it's moved away from that kind of, here are these set in stone ways to ask a gradual dose reduction to we understand that some residents don't benefit from that. And like a truly schizophrenic person
Mhm.
does not need to have their dose reduced if they're stable and they're not experiencing tons of side effects. And, you know, I'll never forget, and Caitlin, I'm sure you got a story you probably can think of while I'm telling this one, but um, I remember I was a young pharmacist and I went into this facility and I just kept saying, "Well, we'll just call her Mrs. Smith. Mrs. Smith doesn't need this Risperdal. Like, she doesn't need this. She is a dementia patient. Like, that's guaranteed what they're trying to use it for is agitation related to that. Let's try to take her off of that, try some pharmacological type interventions, that kind of stuff." Well, I remember finally one of the nurses, because you guys that are listening in that are nurses know the residents the best. I mean, you guys are with them day in and day out. We're in there once a month. Doctors, nurse practitioners are in there perhaps the same amount or more frequent or less, depends. And you guys see them every single day. And finally, this nurse had the courage to kind of pull me aside, being the young pharmacist that I was, and said, "Why don't you go down and talk to Mrs. Smith about what happens when we reduce her dose?" And so I, thinking to myself, like, I'm going to win this battle. I like to win these debates,
Yeah.
stroll my happy self down the hallway into Mrs. Smith's room. And I said, "Hey, Mrs. Smith, what happens when we reduce your Risperdal dose?" And what she said will stick with me forever, because she looked at me straight in the face and she said, "When you guys reduce my dose, in the corner of my room, it's on fire and my brother is in
Oh,
the flames." And she just sat there and let that just sit, on my thoughts. And, what do you say to that other than, "Thank you for explaining
yeah.
what's going on. I won't ask for a reduction of your dose." And so there are times where, these meds are absolutely necessary that we can't do a GDR on them. Um, and I don't know, Caitlin, if you've got any stories you want to share.
Well, there was one. It's a little bit different. It went in a different way. So there was a resident that we'll call him Mr. Smith. He got
They were married.
transferred to yeah, he got transferred to one of the other buildings within the company, but he had been at that specific facility before transfer for a very long time. He loved his activities. He was very involved in going to the cafeteria, socializing, and they just kind of saw like a decline. So they thought, well, okay, well, we'll transfer him over here to this facility. Well, it got worse. So then they brought him back over to his original home. And one of the unit nurses reached out to me. She's like, look, we cannot figure out what is going on. Like, he went from going to the activities all the time and going outside and doing this and that. Now, like, we're about to put him on hospice, and we just really don't want to do that. We want to make sure like there's nothing underlying here. So they asked me to look at his meds. And so the guy was on the new, I don't remember the brand name of it, but it's a new long acting lorazepam.
Mhm.
the extended release. And he was put on that for depression.
Interesting.
But then right. But then he also was on trazodone and Remeron, and I was like, "Okay, wait a minute. Why if he's sedating, he's not wanting to go do stuff, like, he's sleeping a lot," and that was what was described to me. I was like, "Ah, what if we lift some of these meds off and see where his behaviors are slowly, not
Right.
fast, little bit at a time, and let's see if maybe those doses and those medications are no longer needed and things have changed mentally, or maybe they were staggering them on one after the other to treat a behavior that was not getting treated. And so now we had maybe some other chemical imbalances. So we tackled the long-acting lorazepam first, which I immediately was like, "Well, why is this for depression?" But I thought, well, there might be something else that was meant underneath, that diagnosis. So they took that off and he just came back to life. He just started
Well,
going to the activities, but the activity director had left, so he's a little sad about that. But they were able to redirect him using non-pharmacological interventions, pulling him up to the nurses' station, socializing with them, going down there with them, with the people he did know in the building that he wanted to hang out with, like staff-wise, and get him that socialization. And then from there, started lifting up that trazodone that came off, and I do believe he was kept on, the mirtazapine at a low dose, and that was it. And I think he's still I checked on him last month, he's still there today. Well, he did yeah, I think he's still there. So, that was awesome to kinda see how sometimes a change of behavior, even though there are instances where you do need to keep them. Like, that there's no doubt about that. If I was taken from my home and, things going on in my body, like there are definite instances where you may need a little bit of help and that's okay. But there's also instances where like we talked about before where things have changed, their environment changed, their body's changing. That they
right.
may don't need that or a lower dose. And so that's, kind of a story that's always stuck with me and just realizing, okay, like things change and we have to be willing to see that change and play around sometimes with doses and regimens to, change a behavior in maybe a positive way. And for him it worked and it was awesome.
Yeah, and I love that story because we kind of have a story from each angle, one where
Mhm.
we can't reduce, one where we can, and both in which would benefiting the resident. What I love in this setting is that, I think it's a constant we're constantly learning. I mean, just like all of medicine and healthcare in general, we're constantly learning what is the best approach to take. And I remember years ago when something swept across the nation for long-term care facilities called culture change, and that was where a lot of these things that we see nowadays, like liberalized med pass and all these activities where you see residents using I don't even know what the names of them are, but they're like the knives that your kids can use that they don't cut themselves. Like they can give those
Oh
residents
yeah.
and they can chop stuff up because
Yeah.
that was what they were used to doing for, 60 something years. Right. And, I love that facilities are trying to embrace all these non-pharmacological interventions like you were talking about, wheeling them up to the nurse station, interacting,
Mhm.
take them to activities, and really trying to make those activities something beyond just like bouncing a ball around, but trying to do things that are really helpful to these residents to really keep them kind of, feeling like they matter and that they're loved and all that kind of stuff. It reminds me, I guess we could call this segment the "What's in the news?" What I don't we need a better name than that. That's, like, absolutely terrible. But, just to kind of illustrate to everybody that's watching or listening in on this is a constant discussion. It is not something that is gonna go away. Psychotropic utilization is a very hot topic. This actually came from I'm going to butcher this. I don't even know what this organization stands for. I think it stands for, oh, it's California Advocates for Nursing Home Reform. Canner? My
Canner,
southern side wants to be like, Canner, Canner.
Canner
Um,
with a er.
Can or with an extra on there. But this is actually them citing a study that was in JAMDA, which is a Journal of American Medical Directors Association. And I'm just going to read this because I find this extreme, like intriguing. And as a pharmacist, I find intriguing. I think as any type of healthcare professional dealing with residents or taking care of residents, you might find this interesting related to antipsychotics. So they found a significant association. This is what the study said between antipsychotic drug use in long term care facilities and worsening behavior among the residents who received them. So,
Mhm.
like, in order to understand this a little bit better, we've always thought that we would give antipsychotics for poor behavior. Like if you remember from a little bit before this, we were talking about how all the pharmacotherapy textbooks and stuff would say that you would give that for like just to use in a disease state like dementia for behaviors. And that was like a last line approach. But anyways, this study said that they found an significant association between giving those medications and actually having worsening behaviors. The study followed nearly 500,000 residents and found that those given antipsychotics were not only subject to the typical adverse effects like muscle spasms, restlessness, sedation, impaired cognitive functioning. Ain't none of those good for a long term
Right.
care resident, but also experienced 27% increase. 27%, that's over a quarter increase in troublesome behaviors. Residents on antipsychotics were more likely to resist care, abuse others, and engage in disruptive behaviors. The use of antipsychotics in long term care is often justified despite the side effects and increase in the risk of death because they allegedly reduce bad behavior. The JAMDA study is yet more evidence that antipsychotics are dangerous, ineffective, and ill advised for the vast majority of residents. And so, like, if
Mm,
you're in the long-term care space and you're working for a long-term care facility, those kinds of articles are what CMS is also reading, right?
yep.
And that is why we see these like dementia focused surveys and things where they're really trying to make sure that they're on appropriate medications, that they're getting the right care. And so I find that interesting. I don't know, Caitlin, what you think about that, but I find it extremely interesting.
Very interesting. I mean, I suspected it. I mean, there have been smaller studies out there that are, kind of hypothesizing the same thing. This is a big sample size, and it was an observational study. It was done in a retrospective um, pers- method, and
Right.
the one what I do like about this study is that they excluded patients with severe behaviors. So I like that because we know that, like you were saying before to your story, that there are patients that we do not need to, decrease or take those medications away from. And if they would have included in this study, then obviously those patients, if you tried to decrease those medications, were going to demonstrate worsening behaviors, or, they could have skewed the data essentially,
Right.
or them being on it and they were staying on that dose, increasing doses of something that we do see with patients with severe behaviors. We will see a need for decreasing or increasing doses and then maybe decreasing with, those environmental factors coming into their psychosis. So I like the fact that they excluded that. And I just found they did a really good job at composing the study, how they rated the residents, like what data tools they used. And I think it's just a really good resource for our facilities to kind of look at that and, apply it to maybe their patient population and their facilities. I definitely will be using it for sure and citing it in my comments just as a helpful educational tool. It's just, these are just kind of the things that we want to look for. And that's, like you said, it's very difficult to keep up with the change. But this is how the change comes to us is these articles and these studies and these focuses, and when you get one with a big sample size, that's definitely something to kind of, tune into. And this topic is difficult. So these type of resources really can kind of help us use to individualize that care to that patient and apply it and see, well, is this something we want to consider? Like, are we worsening their conjugative function and causing impairment, or are we actually treating the behavior? I just think with drugs, sometimes we have to remember, and it's difficult. The one thing that we fix, the drug can offset something else, and that's all drugs. And this is a good example of that. What are we offsetting, and what's the appropriate time frame of usage to mediate around that offset?
Yeah, and I think that's a phenomenal point because we live in a society that just wants a quick fix, right? I think we live in a society that really wants magic instead of medicine.
Yeah,
I
like
mean, I
my
really think
husband.
that's what people want, the
Yeah,
like Harry Potter it
yeah,
and then boom, like no more
yeah,
dementia, right? And I
right.
wish that was the case. Like that would be really cool.
Mhm.
And I could be a magician instead of a pharmacist, I guess.
Yeah.
Um, but one of the things that I think oftentimes people forget is that they do these side effects. The reason we see this, and I was going to bring this up earlier, but when I first started in long term care, if a resident was on 9 or more medications, they flagged on
Oh,
the
yeah.
roster sample matrix, which is what MD or what CMS, when they would come in
Mhm.
and inspect the facility, they would see that and they would look at that person and look for unnecessary meds and all that. That's since been removed because
Right.
now the amount of meds that we see residents on is massive, 15,
Massive.
20, 30
Yeah,
meds.
yeah.
And it's not because they always needed 15, 20, or 30 meds. Oftentimes, it's because it's treating side effects of other medications, what we call polypharmacy. Um, Goodness, I mean, we had somebody come in to one of the facilities that one of our consultants reached out to me and told me this, that was on over 60 medications.
Oh, bless 'em.
Yeah, and
Mm.
that's not, you can't fit 60 meds in any little med cup
No.
that you guys out there are passing from. Like that's a solo cup full of meds, and that's way too
Yeah.
many. We were able to work with the facility themselves, the physicians, providers, as well as the hospital to get rid of a bunch of those medications. And I think they were on it was still a lot, like 20 or 30 or something like that when I last checked. Um, but yeah, we see this thing called polypharmacy, and that's I think what we need to talk about next, Caitlin, is
Oh,
well,
yeah.
now that we kind of know a little bit about like the psychotropics and a little bit of the history of it. And I didn't even get into all this stuff like with antipsychotics. And you guys that have worked in long term care for long enough know all the different things that have come out where we had facility groups, not, saying anybody in particular, but just moving people from dementia to schizophrenia because that fell off of Casper data. Casper data is what basically CMS gets from all the MDS records
Mhm.
of psychotropics, and that's how you get your percentages for your building as to how many you are on compared to state and national averages. But they had all this stuff that came out. That's why some of these focus surveys even came about, was because of the fact that these facilities were trying to swap diagnoses to get them to fall off of those records, and maybe somebody did go undiagnosed schizophrenic or schizoaffective disorder or something like that, but at 80 years old that didn't typically just manifest itself.
No.
So um, we I didn't even go into all that, but one of the things that I think is the charge for most of us in this setting, whether you're a nurse, whether you're a provider, whether you're a pharmacist, whatever you find yourself doing, you can play a role in this. And that is, just overall health optimization, medication optimization for that resident, and I like that a lot better than deprescribing. We hear deprescribing all the time, like, well, we need to deprescribe off those medications. That's great. That's talking about getting rid of some of the excess meds. We absolutely need to do that. But deprescribing is really part of med optimization because med optimization is saying, how can we make sure that the medications that they're on are the appropriate medications? How can we make sure that we do deprescribe off the ones that are not needed, but overall health is improving, overall quality of life is improving? Because again, like if all we focus on is reducing the total number of meds, but the person's quality of life doesn't increase and the
Right.
person, doesn't have any fewer side effects or something, well then that is kind of a missed opportunity, right? And so I think that's what we should talk about next is how we can all kind of work together in this role of med optimization. And so, kind of just throwing something out, Caitlin, and then I want you to throw out anything that you can think of too. But for our
Mm.
nurses that are out there, I mentioned this earlier. Y'all know the residents best. You know when they're over sedated, you know when they're experiencing some of these side effects, like we mentioned earlier. And you bringing that up to your provider and to your pharmacist, your consultant pharmacist in particular, in your facilities can really help guide some of the decision making, clinical decision making that we are doing when it comes to adjusting or making recommendations for adjustments to their medication profiles. And your feedback is invaluable because we don't see that person every single day, but you do. And so that's just one quick way that I can think of to kind of work together on this med optimization. Caitlin, anything you can think of?
I'll have to back that up too. I mean, I think it's hard from us looking from the outside in. And we really, really, and I know we're not the only healthcare professional that really leans deeply on that documentation and just those nurses' knowledge of those patients because, like you said, they are the ones that see them every single day. And I'll get questions from surveyors. Well, what do you think about this, resonance regimen? And it's a very simple answer. Like the nurses are the ones who see those residents, and behaviors are physical presentation. And we're not physically there to see that presentation. And the nurse's documentation is definitely a tool, but I really think that their observations and their communication to the rest of the interdisciplinary team is very vital. It's very vital. I can give the best pharmacological advice as I possibly can, but my goal is to more of educate those healthcare professionals that see those physical presentations so they can take my knowledge out of my brain and apply it in the best way for that patient because they're the ones who are ultimately there. And so psychotropics and trying to identify these opportunities, like Scott was saying, comes back up over and over, and it's a very big topic. And I think why is because of the barriers that we have to really home in on those patients because we are not there every day. And so that communication is absolutely key.
Yeah. Yeah. And I think when we talk about communication too, one of the trends that we're seeing, and this has obviously increased ever since the whole schizophrenic thing that I brought up earlier and trying to swap diagnoses and things like that is that we've seen an increased presence of psychiatrists and psych providers and their presence in the facilities and seeing these residents that do have a medical, mental illness or anything along those lines that would require a psychotropic medication, um, or whatever the case may be, if it's used off label or something like that. And we really try to work alongside those as pharmacists. Those providers specialize in this area, which is why I find it absolutely amazing to see their presence in these homes because they know schizophrenia better than I know schizophrenia. They know depression better than I know depression. I can be trained on that in school and just like Caitlin was, but that's not our main specialty. That's what they have specialized in. And so I find it really amazing, and there's some great ones out there that we've worked alongside that really take the time to get to know these residents and listen to them and see if the behaviors and things, again, kinda going back to what Caitlin was saying, that that they see documented, but also just in talking with the nursing staff or family or whatever the case may be, that they listen to it and they say, I think this person does have depression or does have anxiety or is schizophrenic or is does have Huntington's or Tourette's or whatever the case may be,
Mhm.
that bipolar that they're looking for, and let's get them on the appropriate treatment for that. And it's no shocker. I mean, a lot of times some of these residents that have bipolar disorder or something else aren't on the gold standard treatments. They're on something that was started, by somebody that might not have known the condition well enough, or just, started them on maybe a first line thing, but didn't make any changes after that to tailor it towards that person. And so these psych providers have done some incredible things in homes to not only get rid of some of the medications, but to go along with what we're talking about, to optimize the medications to provide better quality of life for these residents. And so I think between, all the feedback from nursing staff, all of the feedback from given to our psych providers, our providers just in general is really helpful from our nursing teams and from families as well, just getting to have their input as well if they know their loved one well enough to be able to provide that information is key. But I think, Kaylin, wouldn't you agree? I mean, I think I think what's been highlighted through the years, if I can spit this out, is that really it takes a team,
It
almost like it
does.
takes a village to
Yeah.
be able to control the use of these medications.
Yeah. Yeah, it
And
definitely takes a team.
yeah, and I think, in the past, maybe perhaps like I think even the regulations are an example of understanding that this is really something that requires multiple disciplines. In the past, it was the consultant pharmacists that were the primary ones that asked for gradual dose reductions. Now
Right.
it's a consultant pharmacist. The nursing staff and nursing home themselves can ask for gradual dose reduction, and the providers themselves, whether that be a site provider or a PCP, can make those adjustments themselves. And so it's moved away from just this, well, it's only one party that's responsible, to let's look at this from an interdisciplinary team approach
Right.
and kinda see what happens next from that.
Yeah, I definitely see that movement in a lot of my facilities. They, you know, own it, and patient comes in with a antipsychotic from the hospital at a low dose, immediately decreasing it without me asking. Or they look for opportunities, like I saw one today. They just did a gradual dose reduction. I didn't ask. They did it upon their evaluation of that patient's presentation, that it was appropriate time to try to um, basically establish that lowest effective dose. And if that's zero of it, great. If not, then they establish that lowest effective dose, because the lowest dose is going to be the lowest risk of side effects and toxicity and those things. So we definitely want to try to find that threshold there. But yeah, they are doing an excellent job. I just kind of come in and provide support and where I can and educate as best as I can. But I just really amend all of our long-term care staff and healthcare providers and professionals. They're doing, from what I've seen, an excellent job.
Yeah, I mean, hands down doing a fantastic job. You guys are doing incredible things that in some instances have never been done before
Right.
to the betterment of your resident population, so good job there. And we've had a lot of heavy information here. I think it's time. Kaylin and I have
Oh
a lot
boy.
of different games and things we want to play on here to provide you guys some additional, not just education, but entertainment. One of those games is a pronunciation game.
I'm gonna kill this.
Yes, you are.
Nah.
You're going to be doing so good with this. But I
Yeah.
want this
Mhm.
to be known that sometimes my family members will come to me and they'll be like, "How do you pronounce this drug?" It's almost like
Mm.
everybody thinks that pharmacists just automatically know the pronunciation of drugs.
Oh, my
This is
family gave
like,
up on me.
yeah,
It's
like
that I don't
spoiler
get
alert,
asked.
we don't. We just sometimes we just have to make it up. But I have a
Huh.
drug for us. I'll try to flash on the screen. I'll put a slide in here to flash this drug up on the screen. Let me see. I wrote it down here for us to try to to try to pronounce. All right, so the spelling of this for you guys listening in or watching, if I can put it up on the screen, is Talimogene, and then the last. So this is a generic name. The second part of this is Laherprepvec. So this is um I don't
What
even know what
drug is
drug this
this?
is. I think this is a I to be really honest, those listening in, I Google searched and had AI give me one of the most difficult drug names to pronounce. This is one of the ones
Oh,
that popped up. And so, I mean, Caitlin, like
oh man.
let's let's take the first word there. Um
I got the towel part down.
I mean, and it ends in gene, so I'm assuming it's like a gene therapy type thing. So,
Alamogene?
t yeah, like Telima it's probably
Tel
Telimogene?
Telemogene?
Telimogene? Telimogene. It has, like, limo in it, it's like this is
Yeah.
the Telimogene. This is the
I like the
limogene.
gene part. I can say
Yeah,
the gene part.
okay. So let's lock in, like,
Let's just
Telimogene.
not do the second word that starts with an
The
L.
second
Let's just
one,
pretend that's not there.
I don't even know.
I
It
don't.
starts out with L lay her
What?
para
La
pere pivec. This is listen, y'all, listening in. This
this
is what
this
we
is
do as pharmacists. We just sit here
la
going, who number 1, who named this
la
drug?
her per pivec?
Oh, say that again. I think that was getting closer.
La her per pivec?
I have found that with these
Well,
drug names, it's almost like
this
you
is
gotta say
just
them fast
awful.
to get them.
Ugh.
I'm
Oh,
thinking it's
then
something
maybe
like
nobody will notice.
I think it's something like Lerhet Parrotvec or something like that.
Yeah,
Like, it's gotta
Blair
be
Pivec.
said really fast.
Blair Pivec.
So, I
To
don't
where
even know.
nobody can catch and break it down to see if you said it incorrectly.
I know,
It
well, I'm
just
gonna
all,
look
like,
it up. Hold
just
on 1 second.
mushes together.
How but see, here's the problem, like, even if I put in how to pronounce this Telimagene Parivec, whatever it
It
is,
probably won't pull up. Well,
I
I
mean,
mean,
like
AI
oh,
is
here it
pretty
is, right
impressive,
here.
but
Let me see what this person says here. Laherparepvec is how they said it on there. Laherparepvec.
Laher per oh goodness, Laher
Yeah, we butchered that one.
Vec.
Hold on. I'm just gonna see if we got the first one right.
I'm gonna
Oh, we
see
got Telimagene. So
Telemagene.
Telimagene was right, and then Laherparepvec is the second one. So
Okay, we
you
were
learned
close.
something new, everybody. This is a gene therapy. It's come to find out, I just looked it up. It's a gene therapy cancer drug, is what it looks like.
Oh,
Imligic, imagic, or something like
yeah,
that.
that's the professor that told me, "Don't pronounce words in front of a physician. You're automatically
Yeah, you were telling me about that.
disqualified."
What did he
Oh,
say
yeah.
again?
Yeah, so I loved oncology in school was just I loved it. So I went with an oncology specialist, okay, so he rounded with the oncology team. And they had their residents, the fellows, all that good jazz.
Mhm.
And so, of course, every week we have to do they called it the drug hotspot, where we would be in the hallway and we would present on a chemo drug and, like, give the
Oh,
clinical
man.
pearls of that chemo drug. Well, of course, I picked the field that I can't pronounce anything of, like, at all. And, I would, like, do the YouTube,
Mhm.
pronunciation videos, practice and everything. I mean, I just butcher it. I mean, I would get there to be talking to these residents and these fellows, and my voice is, like, cracking.
Yeah.
I'm like trying to say these words, and my professor, like, after the second time, he was like, "Look, why don't you let Hannah say them?" That was my student with me, and,
Mhm.
he was like, "Y'all can tag team it. Let her pronounce." He's like, "'Cause people are just not gonna listen to you as soon as you can't pronounce words." Like, basically, like, they're gonna
Wow.
think your
What a
intelligence
morale
level is.
boosting comment
Yeah,
right there from your
and
professor.
I'm like, "Fair enough." I mean, I do mispronounce some really simplistic words, okay? My husband gets onto me all the time, so I've just pretty much learned to own it at this point. Like, it
Yeah.
is what it is. Like, I say crown rather than
Mhm. Crown.
crayon all the time.
Yeah.
It is what it is.
I
I
mean, my
don't
wife says
yeah.
wolves instead of wolves sometimes, so and
Oh, that's
I
a good
always like to
one.
point that one out. Yeah,
Yeah.
I mean, I never had that said to me, but it wasn't because I was that much better than you were at pronouncing medications.
He was very honest, but I
Well,
learned a lot.
that is very an honest
Yeah,
statement to
I
give
learned a
to
lot.
somebody. I mean, I'm sure you
Yeah.
walked out of there elevated,
Oh,
but
oh, I did.
yeah,
That kinda
yeah,
stuff just makes me
you're on cloud 9
go
after that.
even harder, so
Yeah.
that's okay.
Well, I I always found that when I tried to pronounce stuff or even, when I got more excited, like, my Southern accent starts coming out more,
Oh,
and
yeah.
so, like, they would sometimes be
Mhm.
like, "Hey, you kind of, like, Southernized your way of just telling us that," and I'm like, I mean,
Goodness.
was it right? Was it right or wrong? I
Well,
don't
there you
know.
go. Right,
Well,
exactly.
hopefully you
It
guys enjoyed
happens.
us struggling through Telemagene Leherprepvec or whatever that was, that we were supposed to be pronouncing, and we'll tackle other drug names that are
Oh, boy.
probably things that you guys see all the time that are mispronounced, and, don't feel bad, I guess is my point on that. If you come to us in the nursing home and you're like, "What is this drug right here, this, you know, metoprolol or whatever, or metoprolol, however you wanna say that. I think it's actually metoprolol, but I always said metoprolol in school. But,
Don't ever go by what I say. It's gonna be wrong.
and we're not gonna go with Caitlin's pronunciations.
No.
But yeah, don't feel bad if you come up to us and say, "What does this do?" or "What is this?" And we have to, like, look at you, maybe puzzled at first just to make sure we are figuring out what it is that you're talking about, because chances are we've struggled through it too. So
Oh, yeah.
don't feel bad about that. Um, I think just to wrap this up, we wanna hear from you guys in the comments on our YouTube channel, wherever you find this. The video is going to be on YouTube, but if you are listening in, it's going to be on Apple Podcasts and Spotify. Can't really comment on there, but we want you to obviously subscribe and follow and do all the things that social media allows for you to do so you can hear more of these podcasts if you like what you heard. We are going to be doing lots more. If you want to see more on psychotropic agents, we're glad to make fools of ourselves trying to pronounce not only the
Yeah.
names but also to explain how they work because it's a mystery on some of them come to find out, but we would love to do those. If that's something that you guys want to hear more of, you can comment on that below. um, and I think just the call is to work together on this. At the end of all of what we talked about, it's to be a team, and that will benefit the residents. And let's get out there and better their quality of life, and kind of optimize their medication regimen. Caitlin, anything else you would add on there?
No, just patient-centered. It's difficult, but patient-centered, and I think if we all do that the best we can, which we may not get it right the first time, but we just keep trying, then
Right.
it will make a difference. Absolutely.
And we'll leave you with one other entertaining piece of information here. This was a news article that's not a serious news article related to psychotropic agents, but it is a news article that I found recently. It was in 2025. This came out of Florida. Thank you, Florida, for bringing this
All the
enjoyable.
good stuff happens in
Oh,
Florida.
it does. I
It
mean,
does.
listen to this. There's a woman. I can't even read the title without almost laughing about just the title. It says woman arrested with bag labeled
Oh,
Definitely not a bag full of drugs.
definitely don't look there.
Yeah, this is definitely not a bag full of
Definitely
drugs.
not.
The news
Yeah.
article goes on to say, and I find this is priceless. It says, spoiler alert, it was a bag full of drugs. That's what the
Right.
news article says. And it talks about there's meth and needles and Narcan and all this stuff in there. But the sheriff that they interviewed, this is probably the icing. This is a cherry on top of this whole news story of this woman that has a definitely not a bag full of drugs. The sheriff that they interviewed, his statement was this: the bag was filled with snacks.
Not.
He says, nah, just kidding. It was actually drugs. I mean, that is a priceless comment that you're gonna have quoted
Yeah.
right there. So I would give that sheriff a high five. So
Yeah, definitely.
there's your not education, that's just your laughter for one of the most bizarre and hilarious news articles that we could find, and we're gonna try to find other stuff to keep you guys laughing as you learn on here. But for now, that's where we'll sign off, and it's been a pleasure, Caitlin. I look forward to the next one. Hopefully, you guys enjoyed it, and we do want to hear from you. So please like, please subscribe, please follow us. We'll put our emails in the show notes, and you guys can email us directly if you would like to hear something on the show, or you would like to, give Caitlin some like props for doing so well. And you can bash me on there if you would like. That's fine too. But we would love to hear from you guys. We really appreciate you listening in on this, and we look forward to the next episode.